see everyone joining. Hello. Hello, hello. Good evening, everyone. As you are joining us, I want to take a moment to introduce myself and my colleagues, as well as go over a few housekeeping notes. So my name is Rachel Lieberman. I'm a director here at the Celiac Disease Center. We are so happy to have you with us this evening to speak to the neurological effects of celiac disease. We know this is a really important topic. We have some fantastic guests with us this evening. And before I introduce everyone, I wanted to just go over some housekeeping notes. This program will be recorded. It is typically posted on our YouTube channel about within a week after our program has met together. And so you will receive the YouTube link afterwards and any other follow-up materials based on what we discuss this evening. We have at the bottom of your screen, there is a little box with a question mark. There is a Q&A function. Please put questions in the Q&A as our speakers are presenting. We will do our very best to get through questions. And I know a lot of you submitted questions as well. When you registered, we have those. We plan to tackle so many of these topics. So we just want to remind you, please don't use the chat if possible, but if you can utilize that Q&A function. We love seeing faces as we're presenting. It always puts a smile on our face to be able to see your faces, but you don't have to if you don't feel comfortable. But the one thing I want to do right now is introduce my colleagues. So I have with me Lindsay Yackel, who is our educational coordinator, who put together this evening's program. And I see a question already about where is the Q&A function. Should be at the bottom of your screen. It says Q&A and it's got a little box, almost like a speak box with a question mark in it. That is the Q&A function where you can put questions as our colleagues are presenting. In addition, I have Dr. Ritu Verma, who is Chief of Pediatric Gastroenterology, Hepatology, and Nutrition here at Comer Children's, and she is also our medical director at the Celiac Disease Center, and we are so happy to have her with us. In addition, we have Dr. Douglas Nordli, who is Chief of Neurology here at Comer Children's, and he is a neurologist who specializes in treating children with neurological issues, focusing on pediatric epilepsy, as well as many other conditions. But we are so honored to have Dr. Nordli with us, and we have Dr. Joseph Fink, who is a clinical neuropsychologist who specializes in traumatic brain injury as well as neuropsychological issues as well. And we have Farida Mahmoud, who is an adult neuropsychology extern, who is with us. She's with the University of Chicago Department of Pediatric Psychiatry and Neuroscience, as well as clinical psychology. So I shouldn't have put pediatric in there for Farida. I apologize. But what is so amazing is we have these fantastic colleagues from the University of Chicago are here to speak to you. So we are going to begin our program with Dr. Fink and Farida Mahmoud, who will present first, and then we'll move on to Dr. Douglas Nordli, and then we will open it up to a Q&A. So please know that we will get to all of your questions the best we can. We know this is a great topic. And before I begin, Dr. Verma, do you have anything else to add? Nope. We're great. Okay, well, Farida, I'm going to turn it over to you. You want to share your screen, and we're looking forward to a great program.
Yeah, and maybe I'll jump in real quick. This is Dr. Fink. Yes. I just want to say a quick word. I'm, as noted, I'm a clinical neuropsychologist. I'm a professor in the Department of Psychiatry and Behavioral Neuroscience. And one of the things that I get to do is see a lot of different kind of cases, not any specialty in per se in GI, for example. I see the broad band of cases, and as I engage in training the next generations of neuropsychologists, one of the other real privileges is I get to work with very talented graduate students who are coming up. And so when I was approached to talk or participate in this dinner engagement here, which if any of you are having dinner, enjoy it. One of the first things I did was thought, who among our talented trainees that are about to get their doctorate and who are perhaps even more immersed in the scientific literature than me for specific topics, might we be able to draw on their talent? And so Farida is working this year in a one-year placement in our institution. And so she actually has a great interest in the gut-brain axis in general. And so I'll turn it over to her and let her really do most of the lifting here.
Thank you so much, Dr. Fink. Thank you, Rachel. Hello, everyone. I am so excited to be here. I'm going to share my screen. Hopefully this works. All right. I think, can everyone see that? I think it's
You're good. You're good.
Right. Okay. Hi, everyone. It's an absolute honor to be here. I am very excited to share and discuss a very important topic that I have so much interest in. So I will get started. Okay. All right. So just to give a quick overview of what I wanted to talk about today, I kind of wanted to just provide a little bit of a discussion about the relationship.
What happened? She told you this?
I think someone's.
Yes, if everyone could mute, that would be great.
So yeah, as I was saying, I would like to discuss the relationship between celiac and neurocognitive domains, kind of providing an understanding about the underlying kind of pathophysiology, what contributes to neurocognitive symptoms, and also kind of provide an overview of some of the dietary factors and lifestyle strategies that we can employ in order to address these various neurocognitive symptoms. So just to get started, as we know, celiac disease is a chronic genetic autoimmune illness that is predominantly, a lot of the pathophysiology is reflected in its inflammatory reactions as a result of exposure to gluten. In fact, majority of the research has indicated that a large percentage of patients are likely to report more neurological than gastrointestinal symptoms, which is one of the reasons why it is not, or it's been more recently diagnosed, because in the past it wasn't something that a lot of individuals would seek their first line of treatment or first line of responding would not to see a gastroenterologist because as a result of the nature of the presentation. Celiac is also more likely to be diagnosed in women, twice more likely to be diagnosed in women than men. And this is attributed to multiple reasons, but if anything, women are also more likely to experience neurocognitive symptoms or at least report more neurocognitive symptoms. These primarily center around brain fog, memory, concentration difficulties. And one of the main reasons that this occurs is because especially during menstruation, pregnancy, and menopause, the significance of estrogen fluctuations is very prominent during these time periods. And estrogen is known to have very strong neuroprotective effects due to its anti-inflammatory properties. So someone who has uncontrolled celiac and who is kind of either during menstruation or menopause or pregnancy, they're more likely to experience more severe intensity of these specific symptoms. So I will kind of briefly touch over these different neurocognitive domains / neurological conditions that we typically would encounter in an individual who has celiac. So these being gluten ataxia, brain fog, memory difficulties, processing speed difficulties, attention and executive functioning, and some mood-related disorders as well. Okay, so hopefully that's not too terrifying to look at, but so essentially one of the primary driving factors that's kind of underlying the pathophysiology of celiac is the significant level of inflammation that's induced as a result of ingesting gluten. And so this is the primary driving force that triggers a lot of the memory and concentration difficulties that individuals are likely to experience as a result of that immune response to gluten. So ingesting a lot of gluten or gluten in general for someone who has celiac is known to trigger an immune response, which essentially releases a lot of what we call pro-inflammatory cytokines or pro-inflammatory biomarkers. So it's almost your body's defense mechanism being activated because your body feels like, if you want to think of it as under threat, right? Like it feels like something's attacking your body. And so one of the most common things that we notice is that individuals who do have chronic celiac is that excessive inflammatory response is very unregulated due to multiple factors. But one of the key mechanisms in which it contributes to a lot of neurological symptoms is like over the long term, and this is something I'm going to emphasize later, is that those inflammatory biomarkers start to attack what we call the myelin sheath. So our nerve cells have this coat or like kind of layer of fat, layer of insulation that protects our nerve cells, but it also is used to speed up the transfer of information across to other parts of our body or to other cells. And so with a lot of inflammation, what it does is that it destroys that layer of myelin over time. And we see that through effects of decreased processing speed, kind of a lot of memory difficulties and brain fog, which I will get into. I think a very key thing to highlight here is looking at the chronic versus acute inflammation impact. A lot of the literature that we look at looks at brain fog as more of the immediate kind of impact that an individual might experience when they ingest gluten, whereas more of the white matter and more like morphological changes in the brain, which I will go over, tend to happen with more chronic, uncontrolled exposure to gluten and chronic persistent inflammation. So as I said, that kind of immune response of releasing a lot of cytokines, one of the things in which it does, which I will get into when we talk about the gut-brain axis, but that inflammation causes damage a lot to our intestinal villi. So the villi are these hair-like structures that line our gastric lining, and they serve a very, very significant impact in protecting our gut, but also preventing bacteria or other kind of microbiomes from leaking into our blood. And so when that villi is damaged, one of the main things that individuals with celiac are likely to experience is impaired nutrient absorption. And these primarily being vitamins, which I will get into shortly. But essentially, these villi over time are no longer working the way they're supposed to be. And that really increases that permeability of our blood-brain barrier. So we end up having a lot of kind of, if you want to think of them like molecules, that we end up going to our brain or going to other parts of their body, even though they don't really belong there. And this is what we call the leaky gut phenomenon. So our gut lining is very permeable. It's very selective in what it allows to come in and out. But over time, with that like chronic neuroinflammation or inflammatory processes, that causes that leaky gut. So we have difficulty maintaining that selective permeability. So one of the most common factors that's underlying neurocognitive dysfunction in individuals with celiac is, again, what we talked about, like nutritional deficiencies, right? So it's like that idea of certain vitamins being not absorbed enough when we eat them because the absorption mechanism is already hindered. For example, vitamin B12, which is known for its criticality for myelin production, that layer of insulation that we talked about that's around our nerve cells. And so one of the things that causes is that persistent demyelination, which can impact our processing speed, our ability to process information at a given period of time and respond accordingly. We can see that a lot of times as cognitive slowing. So you feel like, I have like slow thought processes, or even you feel physically slow. And that a lot of times is because of that slow nerve conduction that happens. We also see individuals with celiac, and again, uncontrolled and unmanaged celiac, decreased vitamin B6 synthesis. And vitamin B6 is critical for one of the neurotransmitters we know as GABA, which is an inhibitory neurotransmitter. Individuals with anxiety or individuals with ADHD are known to have decreased level of GABA production or dysregulated level of GABA production, which is kind of what helps quieten down that anxiety or kind of like your fight or flight response. And so a lot of the correlation shows that decreased levels of GABA are associated with increased risk of anxiety, increased risk of seizure activity. And finally, we also have folate, which is vitamin B9. This is very critical for synthesis of dopamine and serotonin, critical neurotransmitters, which I will get into, that are involved in mood and memory and learning. And so as a result of these reduction in these vitamins, the precursors or the various molecules that make up these neurotransmitters there's a shortage of them. And so the actual byproduct is therefore limited. And finally, iron, we also see individuals with celiac are at higher risk for having anemia. And again, kind of explaining how women are more susceptible because of during menstruation, where there is higher risk of developing anemia. And we also see that this is likely to be seen as more slower processing speed, increased fatigue, what we call mental fatigue or brain fog. So this is a very interesting kind of field, which I think is now getting a lot more attention as we're recognizing the gut-brain axis and how much how much both the gut and the brain are intertwined and how much they really do inform each other. And you can't really view them as separate entities. But one of the factors that results as a result of chronic inflammation is what we call as gut dysbiosis. Gut dysbiosis essentially entails an imbalance of gut microbiome. So our bodies have good, healthy bacteria, or what we call microbiota, that has a lot of different functioning in terms of regulating inflammation, in terms of producing these precursors to form these chemicals, these neurotransmitters, to help with digestion. And so what happens with this chronic inflammation is that microbial diversity, so the diversity of these microbiota in our stomach decreases. So our body is less capable of producing bacteria that has this anti-inflammatory ability. And so we think of it as like more of a cascade, right? It's just like an inflammatory cascade that just keeps going one thing after the next. So one of the most important things of these gut microbiomes as well is that they produce something called short chain fatty acids. And these are chemicals or it's molecules that are really, really good anti-inflammatory properties. And they help maintain that gut lining integrity. So as you know, I mentioned earlier that our gut lining is very selectively permeable, but what happens is when we have a shortage of those short chain fatty acids, that makes it more permeable. And so we're having a lot of things that we don't want coming out, basically. So again, contributing to that neuroinflammation process. So one thing that I don't think a lot of people are aware of, I think a lot of times when we think of serotonin, we think a lot of it is synthesized in our brain, the happy hormone kind of thing. But what we actually found out in literature over time is that serotonin precursor, one of the building blocks of serotonin that's known as tryptophan, 90% of that is actually synthesized in our gut. So a big portion of it is actually formed in our gut. And when we have that damage to that microvilli, what happens is that there is less likely that tryptophan production decreases. But also we know that we have this cross-reactivity component where we have those antibodies, your body, when it gets an infection or you develop some kind of and a reaction to a foreign body entering your body, you start producing a lot of these antibodies. And so these antibodies, again, are what trigger that anti-inflammatory response, pro-inflammatory response. And then therefore, this impacts a lot of that neurotransmitter release and production. So we get a shortage of serotonin, we get a shortage of dopamine, we get a shortage of other neurotransmitters that are key in our neurocognitive and neurological functioning. And also, one of the things that we know is that inflammation increases the breakdown of an enzyme known as monoamine oxidase. Monoamine oxidase is one of the enzymes that helps break down serotonin. And so not only is our body slower in making serotonin because of that high levels of inflammation, but it's also faster in breaking down what we already have. So I won't go too much into detail over this, but I wanted to give a quick overview of these different neurotransmitters that I kept throwing in there, and just looking at how these are associated with our neurological functioning. So list is not exhaustive. These neurotransmitters have a lot more functions than this, but when we think of serotonin, it's very important in regulating our hippocampal activity. Our hippocampus is primarily a lot of times where our memory is formed. It's known as like the memory factory of our body. And so a lot of times with this dysregulation in serotonin, we can see a lot of it impacting our ability to consolidate information, to process information, and obviously with mood regulation, given that, low levels of serotonin are strongly associated with depression and anxiety and other mood disorders. And dopamine is another one that's really important in our executive functioning and our motivation and our working memory. So we have different kind of gut microbiome that help convert a lot of these precursors like tyrosine into dopamine. So again, we have low levels of this microbial diversity as a result of that chronic persistent inflammation. So therefore, these precursors are going to be in such shortage. And then we have acetylcholine, which is necessary for our attention, arousal, and our ability to encode information. And so our ability to focus on relevant stimuli and attend to it so that we're able to process it and store it is significantly hindered when our acetylcholine levels drop as a result of, again, that chronic inflammatory process. And finally, GABA and glutamate, where GABA is essentially known for its inhibitory abilities, so its ability to regulate anxiety, stress, and motor control. And so a lot of times with GABA and glutamate, kind of think of them as both kind of balance each other out. GABA is what quietens things down. Glutamate is what kind of gets everything really excited. And it's used, it's necessary for synaptic plasticity, our brain's ability to form new connections, our brain's ability to form new memories. And so what happens is with that gut dysbiosis, which is kind of that decreased microbial diversity and excessive inflammation, we have so much glutamate activity, but we have less GABA activity and less GABA production. So this results in a lot of excitotoxicity where the neurons are overstimulated. Our nerve cells are so stimulated because there's nothing to kind of quieten them down as necessary. And so we might have difficulty attending to things, let alone processing them, let alone converting them to memories subsequently. So this is a picture of a 71-year-old male who is not compliant with a gluten-free diet, and he has chronic celiac. He's had it for a very, very long time. And without getting into the details, but what I wanted to point your attention to here is that's like the cerebellum, right? So this is the cerebellum, which is one of the main structures in which is affected by celiac, especially over the long term when it's uncontrolled. And so I want to emphasize that this is chronic inflammation and not, someone who's just ingested something with gluten right now. Like this is someone who's had for years where they were not controlling their celiac. So one of the things that we see with neuroinflammation is that we have these cells in our cerebellum known as the Purkinje cells. And our cerebellum, which is a region in our brain that's responsible for motor coordination, balance, and movement, is very susceptible to chronic neuroinflammation. And one of the reasons, there's a lot of reasons why it's still kind of, I feel like the literature is a little bit limited as to understanding why specifically the cerebellum is more of a target. But one of the hypotheses is because it has a lot of what we know as white matter tracts. So if you remember when I said that nerve cell is coated with this insulating material, so those insulated materials, the myelin, are what we find in these white matter tracts. And so a lot of that inflammation will cause these white matter lesions to happen because this myelin is less. There's less myelin production. And so our nerve cells' ability to transmit information becomes a lot slower. One of the most common symptoms that we see with people with celiac is a lot of migraines or development of migraines, especially later on. And one of the factors that contributes to that is when we have a lot of those white matter lesions, we experience something called hypoperfusion, which is essentially decreased blood flow to specific parts of our brain. And that is one of the factors that's underlying, migraine processes. And so with damage to the cerebellum over time, again, emphasizing that this is chronic and not acute, not like acute, is motor coordination, what we call ataxia. So difficulty coordinating body, like upper extremity or lower extremity movements, a lot of balance issues, a lot of weaknesses. Okay, so now that we talked about the physiology, I'm going to go really quickly into talking about, again, just touching quickly on these different different neurocognitive symptoms we're likely to see. So, as I said, that brain fog symptom is one of the most highly reported symptoms that we see for patients with celiac from a neurological neurocognitive lens. And a lot of times what we see is that brain fog manifests in terms of concentration difficulties, difficulties with short-term memory, and attention difficulties, as I mentioned, because of that neurotransmitter dysregulation, and temporary loss in mental acuity and creativity. And I want to emphasize that a lot of the literature that we see is that the onset of these symptoms is very much multifactorial, and it depends a lot on the frequency of gluten exposure, the severity of mucosal injury, so that villi that we talked about in our stomach, how much that's impaired, and other underlying inflammatory concerns. If an individual is, a lot of times, if they have other inflammatory conditions, other vascular risk factors like hypertension, diabetes, hyperlipidemia, we are likely to see a lot more of these symptoms manifest quicker than for someone who does not have these comorbid conditions. Brain fog symptoms are powerful enough to peak within 24 hours of ingestion. And again, this isn't a linear correlation. It's compounded by all these different factors that I just mentioned. And so we can see a lot of that in terms of like deficits in impaired memory recall. So I might tell someone something and kind of they might have difficulty recalling that information later. And a lot of it is because of that. It's not because they're forgetting it. It's just because of that inattention abilities. It's like I have difficulty retrieving that information rather than me completely forgetting what was being said. And this can resolve within days to months following a strict gluten-free diet. And I'll talk a little bit about that right now. But again, quickly going over this. So I want to be mindful of time. So with celiac, again, we know that there is the impaired reaction time, which is processing speed. So you might see that in terms of you feeling very slow in the morning. And this might also happen a lot of times in the morning as well, because your sleep is significantly hindered by that inflammatory process, your circadian rhythm. You might see that a lot with decreased coordination. And you also might see that with kind of planning and organization abilities, that general cognitive slowing that we experience. And again, I want us to think about this in terms of three things. So that idea of acute inflammation, we have this rush of pro-inflammatory biomarkers, which affects our neurotransmitter production, our ability to kind of that permeability of our gut lining. We also want to think of it as like mental fatigue or brain fog. It's like kind of like what I like to think was like the common cold in a way. And also I think the other thing is a way to think about it is that our energy distribution changes, right? Like when we have acute inflammation, our body's energy resource is going towards fighting off whatever's causing that inflammation. And so we're less likely to, again, we have less energy to attend to other things around us. And so you might notice that with tasks that are very demanding and that required rapid mental processing, very complex tasks, you might notice that there's a lot of slowing. There's a lot of like kind of like freezing a little bit of like, I don't know, like I have like a brain block kind of thing. So again, really quickly, but I think I kind of covered this already. The idea that acute versus chronic, I think that's very important to distinguish. For acute, let's say I accidentally ingested something with gluten, even though I've been on a gluten-free diet for a very long time, I am a lot more likely to experience short-term symptoms that we talked about that last usually a few hours, sometimes a few days. But you usually are likely to experience full recovery once the inflammation subsides. And again, this is not linear because it's compounded by a lot of other factors as well. Whereas with chronic exposure, we're talking someone who does not adhere to a gluten-free diet at all, we're more likely to see that slow decline over time, that sustained brain fog, persistent cognitive impairment, that white matter is constantly being damaged and it doesn't have any time to repair itself. So this is again to show you how powerful gluten-free diet can be. This is a patient, a 61-year-old patient who they've done a 1-year MRI scan, and they saw that. So as you can see over here, these are the white matter lesions that I'm talking about. And this was after they've been adhering to a gluten-free diet for 1 year, which I think again goes to show the power of gluten-free diet, which I will jump into shortly. But again, kind of talking a little bit about the mood symptoms, which I've already touched on, but those short chain fatty acids that our healthy bacteria produce are so important in impacting our neurotransmitter signaling and our circadian rhythm, our sleep cycle. And so that's why, you know, patients with celiac are a lot more likely to report symptoms of depression and anxiety, which are frequently comorbid. And also ADHD. I know it's pretty common where you see with recent literature looking at individuals with celiac are 1.75 to 15% prevalent in celiac patients. And this, again, a lot of it is because of those neurotransmitter functioning, especially dopamine and serotonin, which are significantly, and GABA, which are significantly implicated in ADHD. Now, I want to emphasize that with ADHD, even though there's a lot of symptomatic overlap between that and celiac, usually if someone has, you know, symptoms of celiac and they're resolved as a result of like kind of sticking to a gluten-free diet, it's how would we distinguish that between that and ADHD? Well, ADHD symptoms are more persistent, obviously, and there's a lot of other factors that are different about celiac and ADHD. But my point here is that a lot of times people can think that they might have ADHD because of these kind of concentration difficulties, these brain fog symptoms. And usually with patients who adhere to a gluten-free diet, these symptoms are likely to resolve, which kind of makes it more like these symptoms are a byproduct of celiac rather than a pure ADHD profile. And so touching over treatment, which I know is something that is, I'm sure all of you are kind of really eager to get into, but when we think about treatment, again, the number one treatment that we see in the literature is the gluten-free diet. I think by far every research paper that I've come across, whether that's looking at longitudinal data over time, correlational data, it really highlights the gluten-free diet impact. Usually individuals who have earlier diagnosis are likely to show better prognosis and reversal of symptoms. Their gut mucosa is likely to heal a lot faster. And age is significantly a protective factor as a result, especially when we're looking at it from a neurological standpoint. Younger individuals have a lot more faster neurogenesis, faster, better synaptic plasticity, in the sense that your brain's ability to form connections is a lot better when you're younger than when you're older. And so age is significantly a protective factor in that sense. And as we saw from that MRI, individuals who adhere to a gluten-free diet are likely to experience morphological changes, decreased cerebral alterations. And this, again, is correlated with younger, kind of earlier diagnoses. However, for older individuals who have very significant damage of Purkinje cells as a result of years of uncontrolled celiac, are less likely to display that level of recovery because the damage of Purkinje cells is kind of irreversible. And so what we see with gluten-free diet is those antibodies that our body's making are very much decrease in level. And so those symptoms of gluten ataxia that we talked about, like that motor coordination difficulties and weakness, significantly decreases as a result. And again, from a neurocognitive profile stance, individuals who do adhere to a gluten-free diet are likely to show, again, improvement in memory, especially memory retrieval, attention, executive functioning over time. For individuals that have these symptoms persist, a lot of times, again, it's because of age, but also they're more likely to have more vascular risk factors. So we know, like, diabetes, hypertension, hypercholesteremia. These are all factors that are likely to influence that prognosis. And as I mentioned, 34 to 66% of adults experience mucosal recovery after 30 and 60 years respectively, which again goes to show the power of that gluten-free diet in kind of repairing not just the gut, but also those morphological brain changes as well. Also, finally, wanted to just touch really quickly on other factors that we want to consider with treatment. So as I mentioned, the gluten-free diet, but also an anti-inflammatory diet. Omega-3s are very, very well studied in their anti-inflammatory abilities. And I also want to point out to noticing the difference between DHA and EPA concentration. So omega-3s have these two components, these DHA and EPA concentration, EPA products. And DHA is known to have more neuroprotective effects. They both have anti-inflammatory effects, but from at least my understanding of the literature is that DHA has a lot more benefits, neurological benefits. And again, those anti-inflammatory properties increase what we call those short chain fatty acids that we talked about, those byproducts of healthy gut bacteria that help with maintaining our gut line integrity, that help with that neurotransmitter production. And obviously, when we think of, foods like berries, greens, nuts, all of these have a lot of antioxidant effects, which are very, very helpful in decreasing that inflammatory products. And looking at nutritional supplements, so again, vitamin B12, vitamin D, and iron are very, very important. I think that even with adhering to a gluten-free diet, a lot of times mucosal recovery takes a while, and I do think that nutritional supplements are quite important in ensuring, again, that reabsorption process is kind of restored in a way, but also ensuring that your body's getting the necessary supply of vitamins that it's already kind of impaired as a result of that malabsorption process. And finally, prebiotics and probiotics. So as I mentioned, our gut has a lot of healthy bacteria, and the result of chronic inflammation causes a lot of reduction in that healthy bacteria, which again is one of the factors that contributes to that sustained chronic inflammation. And so prebiotics and probiotics are actually one of the most currently researched kind of supplements or products in clinical trials right now when we're looking at neurodegenerative diseases. But for celiac specifically, again, because they help enhance kind of gut functioning, they help enhance that microbiota diversity, and so help modulate that immune inflammatory process. So again, I think a very big, one of the most, several studies actually have looked at have done neuropsychological testing on patients with celiac disease. And at 1 year, they did this first test while an individual was consuming gluten, and then 1 year later after adhering to a gluten-free diet, with caveats. But essentially, correlations have been shown that individuals with who have adhered to that have found a lot of changes, significant changes in processing speed and visuomotor abilities, and that this correlated a lot with serum normalization. So looking at those antibody levels in our blood, and also looking at kind of mucosal healing over time, which, begs the question if possibly the use of cognitive assessments in the future as a way to evaluate mucosal healing, given the significant clinical correlation between them versus, having more invasive biopsies or, blood tests. And finally, I wanted to talk a little bit about the factors that might impede treatment. I think there's a lot of the literature that looked at gluten-free diet talks a lot about the skepticism about having a pure gluten-free diet. There's a possibility of cross-contamination, chronic low-dose gluten exposure. It's still, it's very questionable as to what safe gluten exposure threshold is. What is the most, if I ingest a minimal amount of gluten and I'm very unlikely to experience any symptoms, what is that, minimum threshold? That we still unfortunately don't know that. But I think a key thing that we should know, especially with, the food market expanding a lot right now, is that a lot of the gluten-free products that are sold in markets, Costco being one of my favorite places to go, and knowing that I like to read the ingredients a lot because a lot of the gluten-free products might contain a lot of what we call low-quality trans isomer fat. And these kind of products are known to increase risk for atherosclerosis, which is essentially when a lot of lipids and plaque block our arteries over time. And again, if we think about gluten, we think a lot of it comes from carbohydrate sources. And so you want to be very careful with what you substitute in terms of protein and lipids to ensure that we're not ingesting a lot of the saturated fat, which is kind of what we find a lot in a lot of gluten-free, especially like gluten-free biscuits, and a lot of the desserts. I will say that's what I kind of pay attention to the most in grocery stores. But yeah, that is all me. Thank you so much for listening.
Thank you so much, Farida. That was amazing. So thorough. It was fantastic. I want to turn now to Dr. Doug Nordli, who is going to share some of his thoughts, more specifically on epilepsy and brain fog. And so, Dr. Nordli, I would love to turn it over to you.
Oh, thank you very much. And thank you, Farida Mahmoud. That was such a nice review of some of the important issues and the possible pathophysiology. Just want to tell you a little bit. So as was mentioned, I'm a child neurologist and an epileptologist, and I was, trained in both of those things for, many years, but I didn't know about this entity of celiac disease and neurologic complications until I went on a trip to Italy, and I met ultimately a colleague of mine, Professor Foyce in Siena. And at a conference, he showed a number of children who had epilepsy, and what was peculiar was that they had changes in their imaging. At that time, mostly CT scan, but ultimately, eventually MRI, just as Farida was showing us. And in these children, the reason they came to Professor Foyce's attention is that they had epilepsy. So they had a seizure disorder, and it was related, he could tell, to these areas of injury that were inflammation, let's call them, that were in the posterior region of the brain, just as was illustrated. Posterior region of the brain is the area of the brain that processes visual information. And so that kind of correlated with the location of where abnormalities were seen on their EEGs. And in describing the patients, Professor Foyce, shared that they often suffered from headaches, including migraine headaches, and they had some cognitive issues, like it has been alluded to as quote unquote brain fog. So that opened my eyes to this entity. And what Dr. Foyce showed is that with a gluten-free diet, the vast majority of these symptoms resolved in children. And so I was really grateful for that introduction. And over the years, I paid careful attention to children who exhibit those constellation of symptoms, and want to be sure as a neurologist that I'm excluding celiac disease as a cause, because if it is a cause, it can be ameliorated, or in some cases completely resolved, by a gluten-free diet, just as was said. And I want to share that one case with someone, actually a child who was in my neighborhood, who was about to go to the neurosurgeon because he wasn't recognized that he had celiac disease, and a lesion was identified on his imaging. So grateful that exposure to Dr. Foyce, that saved that boy surgery, and what he really needed was a gluten-free diet, and he made a complete recovery. So in preparation for this, I was, just knowing all of that, I wanted to review some articles, and nicely, Farida went over some of those, and I also reviewed your questions that you pre-submitted, and I've been monitoring the chat and also the Q&A, and I just wanted to validate the vast majority of the questions that you've asked. Number one, as reported, do these cognitive functions potentially relate to celiac disease? And absolutely. How about ataxia? Is that something that's been reported and validated? Absolutely. What about peripheral neuropathy? Yes, also a very multiple publications validating that peripheral neuropathy can be related to celiac disease. How about autonomic dysfunction, or so-called small fiber neuropathy? Yes to that too. And so all of these symptoms can be related to celiac disease. Now, here's the important point. In neurology, the way we're taught to think is based in two ways. One is try to localize where the problem is, and then two, try to figure out what the problem is. So where is it and what is it? So you've seen the images of where it is, this posterior region predominance, whether it's occipital, sometimes involving the cerebellum, and then the connections to the ear, so generating vertigo, vertiginous symptoms. So that's the location. What it is related to, is there evidence that we have laboratory evidence that there is celiac disease. But what I want to point out is that it's not a one-to-one correlation. So one of the questions, for example, which is excellent, is what's the difference between celiac ataxia and ataxia? And the answer is none. Ataxia is ataxia. And so the neurologist's job is to make sure that that's the cause and exclude other possible contributors. Now, Farida nicely went over like some of these, like it could be a coexistent nutritional deficiency, for example, or it could be something that's related to vascular insufficiency and so forth. So I think it's important for us to recognize that it validate all of the symptoms that people are putting in the chat and the questions, but to also underscore that, and the main treatment of them is a gluten-free diet, but to underscore that if those symptoms fail to resolve, then it would be prudent to go and talk with a neurologist about what could be alternative explanations or other things that could be done. So I think I'm going to pause there and see if there's any pressing questions, or if people would like any one of us to respond to questions that you have.
Thank you,
So
Dr.
Doug, maybe I can start off a question. And first of all, thank you so much. I mean, this has been awesome. Farida, it was awesome. So thank you so much. And Doug, as usual, you're synthesizing the questions and answers pretty nicely. I guess my question would be from a diagnostic standpoint, does anyone feel like there's some validity to doing a TTG6? I know in the world of celiac disease, so I'm in that world and you guys are in a different world, but in the world of celiac disease, the TTG6, which is not the normal one that we usually check for celiac, where we check a TTG2, 6 has been sort of associated with the neurological symptoms. Your thoughts on that, and then maybe if someone can give thoughts on copper supplementation. I agree, the vitamin B12s and zinc and iron and all those things, but those are the two sort of questions that I know I address when I see my patients.
Yeah, and I think Dr. Verma is in a much better position to give a good answer to her own questions about those two things. But I noticed the same thing that Ritu's bringing up, is that there is this particular association. But, you know, we have to recognize it may not all be antibody driven. It could be related to other immune factors that were alluded to, well described actually by Farida. But yes, that's the same thing that I came across. But Dr. Verma, I suspect you're far more knowledgeable about that than I am.
Well, you know, with the TTG6, it's not available commercially right now. So that's a big problem. Though, if you look at the labs, especially the work that's being done in England, they seem to be far ahead in terms of the discussions with TTG6. So I guess, you know, there were some questions in terms of a diagnostic process, like how would we know? So TTG6 probably is the future. And then looking at functional MRIs, I know we have studies going on here at the University of Chicago looking at functional MRIs and neurological manifestations in celiac disease. Those, again, are things that we've come up with, but from your world, both in neuropsych and also in neurology, where do you see those in general? Like if you see a patient with ataxia, do you always end up doing a celiac man? I hope you do, but so the answer should be yes. But I think when do you start them on a gluten-free diet, even if the celiac panel is normal? Where do we go with that sort of thing? Doug, I think you're on mute.
Sorry, I beg your pardon. I can respond from a neurologic standpoint. I think, you know, it starts with us with the localization. Do the constellation of symptoms localize to a place that could be consistent with locations where we know celiac disease tends to impact? And then secondly, what is the differential diagnosis of potential causes? A lot of that relates to time frame, but not always. But we're also looking for other aspects. So a lot of the localization and thought processes in neurology is like not just linear, like where is it, but are there any cross sections, any other features that would suggest something else that we'd have to be aware of? But as Dr. Verma said, yes, it's really incumbent upon us as neurologists, and I certainly do look for celiac disease when these things are manifesting. The question I don't have the answer to, obviously, is that people, you know, there are reports in the literature that you could have neurologic symptoms before you have GI symptoms. And so, you know, what do you do if you strongly suspect that? And Dr. Verma and I have had some cases that we've talked about, but let's say the laboratory tests are negative. Do you rely on a biopsy? And there have been cases reported where biopsy was reportedly negative, but it was still suspected that the neurologic symptoms like peripheral neuropathy were related to celiac. So I don't know, Dr. Verma, what's the latest from the celiac world on that?
Well, I think from the celiac world, the biopsy or the antibodies have to be abnormal to start on a gluten-free diet. But I think when we talk about individualized care and looking at the patient as a whole, I do think that if you've done the due diligence with the antibody testing, the biopsy, and it's all normal, and you still strongly feel as the clinician plus the patient that it might be a gluten-free diet, then I think it's important to have some endpoints that you're going to do this for X number of years. It's not going to improve in a month or two. So you would do that, but then it has to be 100% gluten-free diet that one would do like your biopsy proven. That's basically what we talk about with our patients. But again, it's all individualized with each patient and how that patient feels. And to be able to take on a whole gluten-free diet, that in itself, as everyone in the audience knows, is not the easiest thing to do. So that commitment has to happen with that. Anything that you would like to add, Farida? Anything, Dr. Fink?
I'll just add a couple of comments. As I mentioned at the beginning, I'm what I would think of as a more generalist neuropsychologist. So I see patients who are referred for cognitive issues usually, but it could be just a wide range of causes. It could be traumatic brain injury. It could be an earlier incipient dementia process like Alzheimer's. It could be any number of things. And so the point I want to make is we usually actually don't get referrals for, oh, this patient has celiac, please evaluate cognitive function. Instead, it's sort of it works the other way, that we're referred somebody who's having some problems that we're trying to get a handle on and measure. And then what we try to do is cast a very fine and broad net to consider all possibilities. Sometimes I call it like playing zone defense. We consider all possibilities. So it's been very important in my career anyway, in the past 15 years, to recognize that, well, we should be asking quite a bit about, dietary factors and some of the, symptom profile that could point us to celiac. So we certainly have seen patients who have no idea they have it, and we're seeing them for something completely different, seemingly, the cognitive problems. And lo and behold, through the history, we find out that they really need to be tested. My expertise, though, isn't in the actual testing, so that's why I won't comment on all the TTG6 and all of those important breaking developments.
Yeah, thank you, Dr. Fink, for that. And we in epilepsy, we rely very heavily on our neuropsych colleagues. The information they provide is often invaluable. Sometimes in terms of localization of the abnormality, the problems, but also like giving us a sense of the intensity of them. And then in children, it's really important in terms of what do we do about it? How do we respond to that? These features like processing speed and working memory are hit often in every form of epilepsy. So it wouldn't really, probably my thought would be, not be diagnostic, even as precise of a neuropsych testing as you could do. You wouldn't necessarily know that that's celiac disease. And so I think this kind of a venue where we are talking about this as a community is invaluable, because it's not necessarily ubiquitous that neurologists know about this, and our tests may not be, from a neurologic or a neuropsych standpoint, completely distinctive to say that, that's what you've got. So I think you all within the community can play an important role in, if raising this to your clinicians, that hey, I'm concerned about it, I read about this, and could this be a contributor to my problems?
Absolutely. Well, one question, Dr. Verma, if you don't mind, I want to jump in and just cover off ADHD. Farida and Dr. Fink, I would love, this is something that we see a lot of questions in our Q&A, as well as in our pre-set questions that were submitted about ADHD. And my question for you is, within the diagnosis of ADHD, sometimes I think we all have a little of ADHD. I hate to say that, but how does celiac, do those symptoms, and Dr. Verma, you might have some thoughts too. I know as people are seeking answers, sometimes they may go the route, number one, like once you go on the gluten-free diet, do those symptoms sometimes improve? Or Farida, in your presentation, you noted the prevalence was, I don't want to misquote you, but anywhere from 1.5, I believe, to 15%. Is that what you wrote? for patients with celiac. Can you just kind of broadly talk about ADHD again and talk about the diagnosis of it and also just the symptoms? Because I think they all go hand in hand sometimes with some of these other things. People have a lot of questions about ADHD.
Yeah, maybe Farida can add on to what I'll say, but what I'll start is right by echoing something she said is that, ADHD can be surprisingly tricky to diagnose, actually. Straightforward cases are not that difficult, but when somebody presents with attention and processing problems, we do think of ADHD proper as really a neurodevelopmental problem, a problem that is evident, therefore, even in early childhood. Whereas, if somebody develops attention problems that mimic ADHD and yet they come on later in life for whatever reason, I guess it could be celiac for some individuals. For some people, it might be the effects of sleep apnea, or it might be the effects of, fill in the blank. The point being that there are a lot of conditions and presentations that mimic ADHD, but they aren't necessarily neurodevelopmental sort of regular ADHD. And then, of course, there are cases where people happen to have both. The old medical adage, sometimes the dog has ticks and fleas, where somebody actually could end up having both. And those are also tricky cases, but one would expect that the ADHD that's already pre-existing would certainly be exacerbated, made worse by the, if untreated, celiac.
I have a question about the rare diseases like polymyositis, or where you get tested for neurological conditions, and that this is another autoimmune disease like celiac is. Could there be linkages between RA and the myositis, and even the person who asked earlier about MS?
I don't know the answer to polymyositis directly, but I'm at a conference right now in California where it's focusing on rare diseases, but this is actually a topic of, that autoimmune diseases sometimes do not present in isolation, but there could be multiple diseases. I think my concern with the individual who's asking about MS is that, because as you saw, Farida showed us that you can have white matter lesions. White matter lesions are the MRI signature of MS. So one wants to be careful that MS was correctly diagnosed, that it wasn't related to white matter lesions that masqueraded as MS. So I think it's
in order to get a diagnosis for these myositis conditions, you do a biopsy, which is done by a neurologist.
Yes, many times that is the case. And sometimes there are coexisting other features that, give you the diagnosis, like, in the case of dermatomyositis, for example, that you can see the skin lesions as well. But that's true. But so it's a great question. One of the things is kind of getting back to that, comment by Dr. Fink is to really prove this. What we would need would be a huge series, you can imagine, of individuals to know how many times does a disease like, myositis exist in a population. And so could it be a random co-occurrence, or is it related? So those are some of the issues that came up earlier on with celiac disease in the literature, but then article after article proved that no, this is a clear association with these other things that we were talking about.
This is great. Dr. Verma, do you have any other questions? I feel like we have so many. I wanted to actually ask Farida a question. You mentioned about chronic and acute symptoms. Are there studies shown for healing? I know someone in our chat asked about when someone is having chronic symptoms and they go on the gluten-free diet. Is there a time lapse? And they didn't note the disease state specifically, but when people are adhering to the gluten-free diet, when can people start to see symptoms relieve themselves?
Yeah, no, thank you for that question. I think a lot, again, I think the literature, a lot of it looks at the fact that its prognosis is really not a linear, like trajectory of symptomatic improvement over time is really not linear. It's really compounded by a lot of factors. As I mentioned, I think that the idea of if someone is adhering to a gluten-free diet for a very long time, they accidentally ingested gluten, they might have like what we call like flare-ups. So they might have like a little bit of brain fog, a little bit of fatigue and exhaustion, but usually that will resolve within a couple of days, as long as they're not, again, ingesting more gluten. But I think in terms of someone who's not compliant with a gluten-free diet and we're looking at this as something more over time, again, it is compounded by a lot of other factors, their age. As I said, for women, there is a lot of literature looking at that recovery might look different as a result of like fluctuating levels of estrogen. I think also from what I know, that women who have like other conditions like polycystic ovarian syndrome are also more at risk of like that prognosis being implicated as a result of like hormonal imbalances initially. And we're also again looking at underlying other vascular risk factors that also are associated with these inflammatory processes. So if I'm adhering to gluten-free diet and I'm diabetic, or I have hypertension, or I have hypercholesteremia, again, you're likely to perhaps continue experiencing a lot of these symptoms because of the vascular impact that these conditions have. So a little bit of a long-winded answer to your question, but I really do think that it is a very multifactorial factor, like kind of outcome. And yeah.
Well, I want to be thoughtful of our speakers' time that they have given today. I think what is more prevalent than ever is we need a part two. We have so many questions. Dr. Verma teased Lindsay and I as this was planning, and we saw the pre-submitted questions that she said you're not going to be able to achieve this all in one meeting. So I look for more information on this. I think in the future, we hope to have another talk about this and more Q&A, because a lot of you have so many questions. But I want to thank Dr. Nordli, who's at a conference right now, and Dr. Fink and Farida. This was amazing and so informative. And I really just appreciate your expertise. And it's always wonderful being together, colleagues at the University of Chicago, and having these thoughtful discussions. Dr. Verma, do you have any closing thoughts?
All that I'd say is thank you so much to the audience that you've joined us. It's made us feel good that this was a good topic for us to pick for this dinner with the doctors. And as thank you to our speakers. And of course, the star of the show is Farida. Sorry, Doug. And then so I think that the stage that you set for the whole talk was great. And of course, Doug is always good. And I've never met Dr. Fink before, but it's been a pleasure meeting you. I do think that sometimes, when we're done with these talks, there is a disappointment that everybody put in a lot of questions and those were not answered. So I think what I'm going to say here today is that we will have a part two. There will be a part two of this so that we will try and address the questions that you have. So don't be disappointed. We will have another one shortly. I know that I haven't discussed with Lindsay or Rachel or Farida or Dr. Fink or Dr. Nordli, but we're going to have that. And I know just the enthusiasm that everyone has had here, that this is infectious. So thank you so much for joining us. This has been fantastic. But of course, thank you to the speakers. You guys were awesome. We'll have a part two. Thank you. We will.
And the recording will be sent out. Thank you all so very much. Have a great evening. Thank you. Thank you to our speakers.
So much.